All right, now we're going to move to hemorrhagic conditions in late pregnancy. All those others were early pregnancy. Now late pregnancy. There's two primary ones here. And one is the placenta previa and one is the placenta abruptio or abruption. So a previa is where the placenta implants low in the uterus, close to the cervix or covering the cervix or slightly touching the cervix. So that would be a low-lying placenta. And if it's low enough or if it's covering it, she's going to need to have a C-section. That should be found on her 18-week fetal survey. They look at the placenta on that survey, the ultrasound survey, and they also look at the placenta age, do an age on the placenta. On the ultrasound, they look at where is the placenta. They grade the placenta on how old it looks, and they see where it's located. And if it's low or covering the cervix, they will follow, they'll do serial ultrasounds and follow this placenta during the rest of the pregnancy. It is possible as the uterus grows, the placenta can grow up alongside as well. And maybe at the end of the pregnancy, she won't have a previa. Okay, and then abruption, for whatever reason, starts pulling away from the uterine wall before it should, which is after the baby is delivered. So this is a normal implantation. Okay, this is a placenta accretia where it starts to go into the uterine muscle. And this is a placenta previa. It's covering the cervix. It's covering it very well there. And then up here we have an abruption going on, or a placenta abruptio. So this is an occult one where the placenta is attached on both sides, but not in the middle. It's starting to come loose. And once this gives way, one side of that or the other, she's going to have bleeding. All right, we talked about different placental implants that vary and can go from normal to not normal, and this could be a big fat problem. So we have a normal implantation here, an accreta here where it starts to burrow into the wall, the muscle wall. We have that's an accreta. We have an increta where it starts going to the other through the end of the wall, and then a percreta where it definitely passes through the muscle of the wall. And that's very significant. And because how are we going to get the placenta out unless we get the uterus out? I mean, we have to get the uterus out. This is sorry, you got to have a hysterectomy. There's just no other way we can do that. Different pictures of previas. Here's a partial and marginal and complete and low lying. Those are all different. Okay, so we have a partial previa here and a total placenta previa here. You can see where it goes all the way through. This placenta was implanted over the cervical os, so they had to go in and take the baby and take the uterus. More pictures of the same. We have an abruption here, you can see. Okay, and then for concealed hemorrhages, things that we would do is assess the fundal height. It might be higher than normal. Rigid abdomen, remember internal bleeding. Uterine baseline may become higher. Abdominal pain, signs of shock, UPI, and think about the type of D cells you're going to have with this UPI. You're going to have pretty significant D cells with these abruptions going on. Decreased baseline FHTs and vaginal bleeding that may be slight or absent if it's an occult bleed. Here's an area of detachment again, the placenta, baby, and uterine wall. And nursing interventions, notify the doctor immediately, maybe the OB, and if this pregnancy is a viable one, then anesthesiologist. So again, this is late pregnancy, so it should be viable as long as the baby is alive. IV fluids, same things again, you guys, as that ER patient. IV fluids, transfusion, O2, vital signs. Here's the thing that is the little caveat during pregnancy. If mom comes in bleeding at all, we don't do vaginal exams. Okay. And we're going to monitor her for the uterine tone and the fetus, if the fetus is okay. So decelerations, are there any decelerations on the monitor that would trigger our minds to it becoming an abruption and becoming a severe problem? Okay, and then a Foley, yes, and abdominal prep. If it's a fetal demise, we're going to prep her for induction and delivery as soon as possible and watch for DIC. So this is a picture of a placenta, the other side of the placenta. So the side that's attached to mom and the abruption. So you can see the blood clot in here. Okay, what would the baby look like? Well, it's an abruption. So late decels, yes, uteroplacental insufficiency. And you can see once these uterine contractions really took off here and close together, baby just bottoms out. We've got to get that baby out of there. Okay, next we have hyperemesis gravidarum. And this is intractable nausea and vomiting causing weight loss, fluid and electrolyte imbalance, and acid-base imbalance. Risk factors could be family history, personal history, female gestations, nulliparity, so her first pregnancy, could be a young age of the mom, migraine headaches, motion sickness, elevated HCG levels, and severe reaction to HCG. And I think that's kind of what we tend to see when somebody is this sick with this. It's not psychological though, that's for sure. Okay, here's poor mom leaning over the bucket. Okay, hypertension in pregnancy. This is one of the big classic diseases in pregnancy, or PIH. You'll hear it termed some different things. We've got a picture here of proteinuria in the urine. We can see lower extremities getting more edematous as time goes on. We've got the lungs being affected, blood pressure, heart, and lungs being affected. Okay, pregnancy-related hypertension. There's a high incidence of this and death from this in mom and or baby, and it results in an earlier delivery. Pregnancy-related hypertension. Hypertensive disorders in pregnancy, there could be different types. So chronic hypertension is one of the types it could be, but this one is where mom has already had the hypertension. Her blood pressures have been elevated during the office visits. Maybe she started off at 140/90. That's still hypertension, okay? And this, to be chronic, it develops before 20 weeks. Gestational hypertension develops after 20 weeks of pregnancy, up to 48 hours to 1 week postpartum. So just because she's delivered her baby and she's on postpartum, it doesn't mean that you don't have anything to watch for. You've got to watch for bleeding. You also need to watch hypertension that starts after the baby is delivered. We had one not too long ago. Okay. So another graphic to just outline this for you. Hypertension in pregnancy is the big umbrella up here. And then that can go into pregnancy-related hypertension, PIH, and it begins after 20 weeks, or chronic hypertension begins before 20 weeks, but still goes down to the superimposed hypertension and goes over. So chronic hypertension, we had a patient one time who was about 40 years old, and she came in with a new pregnancy, and she was so happy about it. We were happy for her. And she was some sort of a lab phlebotomist, or she was a lab tech in the lab. And her blood pressure initially was 140/92. And we told her, you've got hypertension. She said, no, I don't. And we said, yeah, you do. No, I don't. So what happened with her name was Georgine. What happened with Georgine is she got as far as 28 weeks and then got so sick that she had to go in for a C-section. We had to take the baby out at 28 weeks and let her recover to fix this hypertension in her, because again, that's the only way to fix it, is get rid of the trigger. Okay, so these both go down to here now. So you've got chronic hypertension imposed. So all this is so far is elevated blood pressure. Now, when we get down here, we're going to go to other things. So not only elevated blood pressure, but preeclampsia. That's the next thing it can go to, where you have proteinuria. And then it can go to eclampsia, where you have seizures starting. Okay, could lead to HELLP. Okay, hemolysis, elevated liver enzymes, low platelets. So this could eventually go into a HELLP syndrome. Vascular pathological changes with preeclampsia, blood pressure keeps going up. So here's the triad of symptoms for hypertension in pregnancy. We have weight gain or edema, that can be the weight gain. We have hypertension, and we have proteinuria in the urine. Protein in the urine will occur when you start using the protein molecules. And that's a problem for mom. She's going to have protein spilling out her urine, and we don't want her to. We want her to use fats and carbs for her energy. So eclampsia, new onset of seizures in a woman with preeclampsia, and then possible life-threatening complication is HELLP syndrome. The only known cure is delivery of the fetus. That's the only known cure. Once Georgine was delivered, guess what? Yeah, she did good. Okay, draw your PIH patient. Use that pregnant patient. Now that we're in complications of pregnancy, use the pregnant patient picture and draw what you can. It is a very good way to have your brain integrate the information that we give you and then be able to process it and put it back out. That will help you understand test questions better. Okay, ask yourself questions. What would I do if hypertension is going to cause vasospasm? We know that. We know that from our med-surg patients. So a vessel that should be this wide, it is now vasoconstricted and it's this wide. So for mom feeding her baby, it's a problem. Okay, so what are generalized vasospasms going to do? They're going to affect the main organs, the kidneys, the livers, the brain, and the lungs. Signs and symptoms: nausea, vomiting, liver tenderness. That's huge. Severe edema, and then right upper quadrant pain in her abdomen. So right where the liver would be, she's got pain. Therapeutic management, we're going to try to prolong the pregnancy as long as we can, as long as the baby is doing okay. If the baby starts compromising, then we may take the baby. The goal with medical management is to prevent seizures and control hypertension. Okay. Therapeutic management and nursing considerations: bed rest, seizure precautions, protein diet to replace the proteins that are lost, blood pressure assessment, daily weights, proteinuria, deep tendon reflexes, lung assessment, CNS assessment, fetal kit counts, and lab monitoring. So most of these make perfect sense. The only other thing would be a type and screen for her. Okay, let's see what we got. Oh, medications. Medications for PIH be mag sulfate and antihypertensives. The mag sulfate is going to depress her CNS and get her a little groggy, probably, depending on how much and how long she's been taking it. Okay, when a blood pressure is over 160 or 180, then and systolic 105 or 110, that is when we're going to start applying some of these antihypertensives, whether it be hydralazine, nifedipine, or labetalol. Okay, and then they might also have her take low dose aspirin to prevent preeclampsia. Okay. Additional interpartum management: always monitor the fetus, control the pain, induction, right? Mag sulfate, okay, blood pressure, respirations, DTRs, and urine outputs. Okay, down below here, magnesium toxicity. Let's talk a little bit about that because you need to know this. Magnesium toxicity, think about this. Magnesium is a central nervous system suppressant. It depresses the central nervous system, the brain. So her respiratory rate should be over 12, between 12 and 14, and she should have some oxygen. So we would recommend 95%. And we want to recognize if there's absent DTRs, because that's significant. That is a sign of magnesium toxicity. Flushing, altered level of consciousness, hypotension, and serum MAG levels. That's what we would test to confirm what's going on. Intrapartum management, always have calcium gluconate at the bedside